AT Medics is a GP founded and run organisation that was created about 12 years ago. It started with one surgery with just 2,000 patients, and now we serve over 140,000 patients. AT Medics directors still have incredibly hands-on approach to both primary care and the running of each of their practices. And what that means is that we can see firsthand the inefficiencies that have developed in primary care over time. The issue with that scale means that we then see how much those inefficiencies matter when you replicate it across 26 sites. And so that really has given us a very, very clear platform both to want to innovate and to deliver innovation successfully over scale. So the three innovations that we're talking about today that we piloted were the document handling, signposting and web access, and the buddy system for GPs.
Document management was something that I realised when I was practicing as a GP. I was receiving about 50 to 60 letters on a daily basis, and I realised when I was looking at these letters that, am I the right person? Do I have to be reading this letter, or can someone else safely deal with this letter on my behalf? So that's what springboarded document handling as a process. The admin staff were given a new way of working, and they were much more autonomous in terms of how they worked. They were able to make decisions on a daily basis that they weren't used to making before.
It's obviously increased my knowledge in the clinical side of things. I also feel that I'm able to action what the doctor can, so stuff that doesn't need a doctor, I can probably action it, so it's just easier for the patient as well.
The reception staff are empowered to open all the letters, take out all the duplicates, and then look at the remaining letters. What's involved is them making a judgment as to who that letter should be sent to. It could be a healthcare assistant, it might be a nurse, or finally it might be a doctor.
Clerical staff have always been used to receiving documents, but not necessarily having such a big role in what happens with that letter. So we needed to make sure that the process was really safe, so that the right letters were being seen by the right members of the team. So there was really in-depth work done with the admin staff in order that they would be properly able to assess the letters and not miss things that were important.
With the training, initially I felt that the training would take a long time. We're talking about admin staff, and it would take a long time for them to be upskilled. In actual fact, we realised in a number of practices there was only about 2 to 3 people that dealt with the incoming mail. So in terms of numbers of staff, it wasn't that difficult. In terms of time taken, I spent 1 hour doing a WebEx meeting with the clerical staff, followed by one-to-one teaching. So that time was definitely well spent because it saved GP time. We realised GP time is the most valuable in terms of the clinical team, and in terms of time saved, it was well worth it.
So I think one of the important things, and the reason why I think it was successful, is that we all felt a part of the process and the change. So at various steps we were asked for our input, and things were tweaked and changed so that it felt comfortable, that it could fit for how it works in our own practice, which may be slightly different from how it works in another practice. So I think every GP's concern will be that you will not see a letter that is important for your patient, and that an action won't be taken because someone clinical didn't review the letter. But actually, if you are just removing letters that don't ever need your action or are just filed for information purposes, it removes distractions from the letters that you're actually reviewing that need your input.
Some of the obstacles that we came across were with respect to the policy and procedure, but that was a good thing because it was the first time that we were starting this process, and we realised we had to change it several times. At least twice a month, I sit down with my manager and we look at the letters and we see exactly what happened. So we look at letters that were sent to management, to receptionists as well as clinicians, and we make a judgment as to whether that process was safe and whether that process was followed through effectively in terms of read coding. When we took over a new practice, I was quite surprised by how quickly we were able to introduce the process. Within 1 week, I was able to train the admin staff, talk to the clinicians, put all the processes in place, and the document handling was fully incorporated within that practice.
I don't think we could underestimate the amount of impact this has had. So I've gone from probably receiving 40 documents every day to receiving certainly less than 10 and often 5 or 6. So the amount of time that is spent reviewing those letters is dramatically reduced. And what it's meant is What you can do then with the documents that you have is spend much more time reading them properly and in depth, coding things as you go through, changing prescriptions. It's a much more streamlined process.
I would say to practices considering document handling as a process, there's probably 4 simple steps to this. The first step is looking at how long it takes for documents to be handled in your practice, how long it takes for them to be opened, to be scanned, to be sent to GPs, and how long GPs are taking to read those letters. Second aspect to this is devising a protocol to deal with letters so that admin staff are fully aware what to do, as well as GPs. Thirdly, training needs to happen for admin staff and clinicians. And lastly, an audit needs to take place on a regular basis once the process is in place.
We decided we needed signposting because 60% of our patients who see GPs actually don't need to. They could have been seen by a different clinician, they could have been seen elsewhere, perhaps at a pharmacy, or they could have used a self-referral and managed their care themselves. So we were wanting to make sure that patients get the care that they need, but in the most appropriate way.
Now that I've got children, I find that the triage service is excellent for me to be able to speak to a doctor and get advice over the phone if it's something minor, and also if it's something major, to come in and they will give me an appointment around my schedule. So that's the best thing for me as a parent.
Signposting initially works when a patient calls or comes in, so the first point of contact for signposting is reception, admin staff. So a patient would perhaps call for an appointment, they wouldn't necessarily know that the best course of action wouldn't be for them to see a GP, so they'd ask for an appointment. Reception would then advise the patient on the best thing to do for the condition that they're coming in for. So let's say, for example, a patient called up and they were wanting a repeat sick note, Med3. The reception would find out as much information as they can. So they would ask the patient if they've had it before. If they had, they could then advise the patient to go online onto our website and fill out all of the details about the sick note, the time that they're needing it for, and then ask the doctor to do that, not via an appointment, but during their admin time. When we began designing the process for signposting, myself and one of our doctors, we sat down, we had a look at the clinic's telephone calls, face-to-face consultations for the next week or so, and we had a look to see the different things that patients were booked in to come in and see a doctor that perhaps didn't need to, and then we freed that appointment up. We then created flowcharts so that the staff that were using the protocols could easily look and remind themselves of how the protocol worked. So then we had training sessions, we had group sessions on how to signpost, what to expect. Some patients initially might be worried that if they're signposted, they're going to have less care than they would have if they were seeing a GP. So it was about encouraging our staff to reassure the patients and let them know that actually this is the best course of action for them. It's impacted other practice systems quite a lot, mainly the availability of appointments. So because lots of patients are now being signposted, that frees up appointments for patients who actually do need to come in. So that's on the telephone and face-to-face. So I remember an incident once where we had a fully booked clinic and a parent of a child called up. They were very unwell, they needed to come in. Of course we squeezed them in, we did as much as we could to get them seen, but on reflection, looking back at that clinic, there are plenty of things that actually could have been dealt with by signposting. And actually I think that was one of the key things that made us initiate this whole process, because we then understood that actually there's a risk of patients who need to be seen not being able to be seen because patients who don't are. Patients' access to services has really improved since we started using signposting. Patients are able to, for example, go onto our website and have a look at the self-care section. They can find out lots of different information, there are leaflets on there, there's advice, and they can find out, perhaps using an example of a newly diagnosed patient, say with diabetes, they can have a look at the self-care, they can find out much more about their condition and have a fuller understanding. Some people could think that there might be patient safety issues, but we have ensured that there is rigorous training for all of our admin staff, but also the things they are able to signpost are things that there wouldn't be a significant risk if something did go wrong. So although we have never come across something happening that put a patient at risk, if worst case scenario somebody was signposted for something that perhaps they should have come in for, the areas that we do signpost wouldn't allow a clinical risk to happen. My advice to other practices who are thinking of starting signposting would be to get their admin staff involved from the very beginning. So to run audits, for example, including the admin staff, letting them know what they're auditing, to find the areas that patients who are coming in to see the doctors perhaps don't need to, and start with that first. So have a core group of areas that patients could be signposted. And once you have the audit, you then know which areas to focus on. You can then create processes, so steps for the reception to take, foolproof steps, so they know when to signpost. We as an organisation have 26 practices across London. This has been rolled out to lots of them, and it's really worked well. The admin staff have taken it up, they've really enjoyed it from day one really. They've really been empowered by the new services that they're able to offer patients that in the past they had no idea about. So any practices that are considering, I would definitely recommend it.
So there's a need for the buddy system because I just felt that a lot of the time when I was doing telephone clinics, I was spending time not doing clinical stuff, the stuff I'm trained to do. And I found that the tasks that were being generated as a result, again, I didn't need to do many of those tasks. And so I really felt that there was a much better way of working so that doctors do what doctors are best at, and that time which is precious, is used appropriately. So the way the buddy system works in practical terms is me and my buddy will sit side by side. We'll both have EMIS systems open. She'll have her own, I'll have my own. We'll have a list of calls. Someone else asked me about this and I describe it as dancing with somebody. You learn each other's ebbs and flows and movement. So the buddy I work with, who's Magda, will understand that my call is coming to a close and she'll call the next patient. So when I finish my call, the next patient is waiting, or they might wait 30 seconds or a minute while I might just finish typing up. If, for example, she's heard that I've said to the patient, you might need an x-ray, because she's sitting right next to me, she'll open up the patient's records, open up the x-ray form ready for me just to type in the information. She'll then save it and send it. So in that way, I just feel my day is much more efficient. I'm able to get through many more calls, and I'm spending less time doing the stuff that I don't really want to be doing, and the patients get a much better service because we're turning around requests and queries pretty much on the same morning. The benefits of buddying for admin staff is staff become much more trained because they're sitting side by side with the GP several hours of the day, listening to the advice, listening to how GPs are managing stuff, so they're really learning by doing.
It's definitely a more exciting job because, you know, you're not just sitting there talking to people. You're talking to people on the phone, you're encountering different avenues, you're thinking of new solutions, you're helping the doctor. It's very rewarding and makes me feel part of the team, it makes me feel respected.
The way patients have responded to speaking to a non-clinician sometimes to start with has actually changed over time. And as patients have learned the way that the surgery works and the systems that we have, they've become much more comfortable. And I can't remember the last time we had a problem with that, because patients know that the doctor and the buddy work so closely together that actually sometimes it's much quicker for them to get what they need, really. So we audit the benefits of the buddy system really in 2 or 3 ways. I think the first thing we were really keen to do is look at the attrition rate of calls. How many failed encounters were there? And clearly that's gone down, and that's something that we keep monitoring on an ongoing basis. The second is we look at how many cases were dealt with by the buddy and not the GP, and we found over time that as their skill has expanded, their range of cases that they can deal with has expanded. And the third thing I think, which is the most important, is patient satisfaction. And we've seen very, very clearly that patients are very satisfied with the response and the service that they get through the buddying system. For us, it's been revolutionary. It's really changed the way we work. It's made our telephone clinics much more enjoyable. And I guess the most important thing is that we feel we're offering our patients a much better service in terms of quality, in terms of access, in terms of the turnaround time, and satisfaction scores are there for everyone to see how successful the whole project's been. If you're thinking about rolling out the buddying system, I think the key things you need to do are 1, identify your buddy and just start to think about what types of tasks you want them to do. If they don't understand about referral forms, they don't understand about admin forms you deal with, maybe sit down and teach them those so that they're of benefit straight away. Then I would probably say do it. That's the best way of learning. Sit down with a buddy, maybe do an hour of calls. Once you finish doing those calls, sit down and reflect on what went well, what didn't go so well, what your buddy might have said. I think the phraseology is actually the key thing because clinical staff are trained in how to say things. So teach your buddy what types of words to use, how to structure a sentence, how to reassure somebody. And once you reflected on that, have another go and see how it goes. And you'll learn along the way. After you've done it maybe 2 or 3 times, you'll see what the key themes that are coming through for your patient population. If it's a recurrent thing, for safety, I would protocolize that so that it's written down. And for another buddy, because you might have 2 or 3 buddies, they don't have to go through the same long process again because they already know what you've agreed you're going to do internally in your practice. So I think learning by doing is very, very important. And I think you'll find that actually your admin staff already know so much. We just don't realise because we don't sit with them, but they know so much, and just by sitting next to you, you'll appreciate what they know, and you can then start to learn where the gaps are and then work on them as you finish each clinic.
For AT Medics, we are working very hard to make sure that patients can access healthcare in the same way that, say, they access their online banking or their gas or electricity. That's just the start of the journey, and we know that we need to carry on innovating in order to really improve access and deliver care that's required for the population that we now care for in general practice, which is a mixture of episodic illness, but increasingly is about caring for people with long-term conditions and the frail and the elderly.
I think it's so important that we start to think very, very carefully about not just what we do, but what every member of staff does. And there are so many skills that we can draw on, and that we're not alone in trying to keep up the surgery. And so I think innovation is critical, and us as GPs, we're the experts in what we do. And so it's so important that we're engaged in the process of innovation and change. But we can't do it ourselves. We really need to involve the whole practice team.
I would say to new practices, change can be very difficult, but the end point is it's definitely worth it.
If you can do something that doesn't impact negatively on patient care but helps to manage workload, then I think that's really important.